welcome back to the Deep Dive.
Always a pleasure to be here.
Today we're diving into a topic that's pretty crucial for anyone in the world of transplant and oncology infectious disease.
Definitely hits close to home for both of us.
We're talking about extended infusion of beta-lactam antibiotics for febrile neutropenia.
A real bread and butter issue.
Absolutely. And, we're focusing on a recent study that really caught our eye, the 2024 Laporte-Margos et al. Paper.
Ah, yes. The BEATLE study, a randomized clinical trial comparing extended infusion, or EI, with intermittent infusion, too.
Right. And, you sent this in, so clearly it's something that's on a lot of people's minds.
For good reason. It's a question that comes up all the time in practice. Is EI really the way to go?
So let's unpack it.
Let's do it.
So the BEATLE study was conducted across 4 university hospitals in Spain, and they enrolled 150 adults with febrile neutropenia.
Okay, good sample size.
Yeah, and these patients were either going through chemo for acute leukemia or had a hematopoietic stem cell transplant.
So we're talking about a seriously vulnerable patient population.
Yeah. Right, exactly, where infections can be a real life or death situation.
And that's why this question of EI versus TISIC is so critical, because the way we administer these antibiotics could have a huge impact on these patients' outcomes.
Makes sense. The thinking is that extended infusions should keep those antibiotic levels nice and stable, maybe leading to better bug killing and fewer complications.
In theory, yeah, but does it really pan out that way?
Well, that's what the BEATLE study wanted to find out.
And I've got to say, one of the things that impressed me right off the bat with this study is how they defined treatment success.
Oh, yeah, how so?
It wasn't just about knocking down the fever. They went further. They looked for defervescence and no need to switch to a different antibiotic within the first 5 days.
So a much more holistic approach that really reflects what we're aiming for in clinical practice.
Exactly. We want to see that fever gone, and we want to avoid unnecessary antibiotic changes, which, as you know, is huge for antimicrobial stewardship.
For sure. You don't want to be bouncing between different antibiotics if you don't have to.
And that's going to be a key point to watch when we look at the results. Did EI actually lead to fewer antibiotic changes?
Right. Or did it actually lead to more, because clinicians were maybe getting a little fixated on those drug levels and hitting specific PK/PD targets?
Yeah, that's the million-dollar question. Does all that monitoring actually translate into better patient care, or could it backfire?
Okay, I'm hooked already. Let's dig into those methods and find out exactly how they set up this study.
Sounds good to me.
Okay, so let's get into the nitty-gritty of the methods. How do they actually conduct this study?
Well, they started with a 1.1 randomization, meaning each patient had an equal shot at being in either the EI group or the TIG group.
And they didn't lock the clinicians into using a specific antibiotic, right?
Nope, that's what I liked about it. They could choose from piperacillin, tazobactam, cefepime, or meropenem.
So basically whatever they felt was best for the patient.
Yeah, it makes the results much more relatable to real-world practice.
Because we know in real life you're not always going to have just one option.
Exactly. You've got to be able to adapt to each patient's situation.
But they did more than just pick an antibiotic and see what happens. They were pretty rigorous about monitoring drug levels, aren't they?
Oh, yeah, absolutely. They actually took blood samples to measure the antibiotic concentrations in each patient.
Makes sense.
Yeah.
You want to see what's actually going on in the body?
That's the key. It let them figure out if each infusion method was hitting those all-important PK/PD targets.
Speaking of PK/PD, I have to admit, I still get a little confused sometimes.
Yeah.
Can you give us a quick refresher for those who might not be pharmacokinetics gurus?
Sure, no problem. Think of it this way. PK is all about what the body does to the drug, how it gets absorbed, distributed, metabolized, and eventually eliminated.
Okay, so it's like the drug's journey through the body.
Exactly. And then you've got PD, which is what the drug does to the body, specifically how it tackles those pesky bacteria.
So PK is the journey and PD is the battle.
You got it. And those PK/PD targets are all about finding that sweet spot, where the drug concentration is high enough for long enough to wipe out the infection without causing any harm to the patient.
So basically, they were checking if EI was better at hitting that sweet spot compared to TI.
Yep, that was the big question.
Okay, so we've got the setup. We know who the patients were. We know how they were randomized. We know how the antibiotics were chosen. And we know they were keeping a close eye on those drug levels. Now, the big question, what did they actually find? Did EI live up to the hype?
Well, let's get into those results.
All right, drum roll, please. Let's get to the heart of the matter. What did the BEATLE study actually reveal? Was extended infusion the champion we all hoped for?
Well, buckle up, because this is where things take an unexpected turn.
Oh, really? Lay it on me.
The study showed that the main goal treatment success at day 5 was not statistically different between the two groups, EI and ITI.
Wait a second. So you're telling me that even with all the theoretical advantages of extended infusion, it didn't actually lead to better outcomes?
That's what the data seems to suggest. And remember, they used a very specific definition for treatment success. It wasn't just about getting the fever down. They were looking for both defervescence and no need to switch antibiotics within 5 days.
So a pretty comprehensive measure.
Yeah, a real-world marker of success.
But I'm still puzzled. They were so careful about monitoring drug levels and hitting those PK/PD targets. Shouldn't that have translated into better clinical results?
Logically, you would think so, right?
Yeah, I mean, what's the point of all that monitoring if it doesn't actually help patients get better?
And to be fair, the study did find that the EI group hit those PK/PD targets more consistently.
Okay, so they were achieving those desired drug concentrations.
Exactly. But for some reason, it didn't move the needle on the actual outcomes. No statistically significant difference.
So it's like we're seeing a disconnect between what's happening at the micro level with those drug concentrations and the big picture clinical response.
Precisely. And it's a good reminder that infectious diseases are complicated beasts.
Right. There are so many factors at play beyond just hitting a certain drug level.
The body's a complex system, and infection is a dynamic process.
Absolutely. Okay, so no clear winner in terms of treatment success.
Mm-hmm.
But you hinted earlier at another curious finding, something about more antibiotic changes in the EI group.
Yes. That's where things get a little paradoxical.
Intrigue me.
They actually found a trend towards more antibiotic modifications in the EI group. Not statistically significant, mind you, so we have to be careful with interpretation.
Right. Always got to be cautious.
But it raises a fascinating question. Could EI sometimes be leading to unnecessary treatment escalation?
Hold on. Are you suggesting that all that close monitoring might be making clinicians jump the gun on switching antibiotics, even if the patient's actually doing okay?
It's a possibility. Maybe seeing those drug levels fluctuate even within a normal range triggers some anxiety and leads to premature antibiotic switches.
It's almost like too much information can be a bad thing.
Sometimes less is more, you know.
It definitely challenges that assumption that more monitoring automatically equals better decisions.
Sometimes it's about trusting your clinical gut feeling, too.
So considering all this, the lack of a clear advantage for EI and the possibility of more antibiotic switches, what's the bottom line for those of us on the front lines treating febrile neutropenia?
I think the key takeaway is that we need to move away from this idea that extended infusion is always the superior strategy.
Okay, no more dogma.
Exactly. This BEATLE study shakes things up and reminds us that a one-size-fits-all approach is rarely the right answer when it comes to these complex infections.
So we need a more personalized approach, tailoring our decisions to each individual patient.
Absolutely. You've got to look at the whole picture: renal function, severity of illness, suspected bug, even local antibiogram patterns.
It makes sense. I mean, if a patient has wonky kidneys, frequent drug level monitoring and dose adjustments could be a real headache.
Yeah, in those cases, the stability of EI could be a big plus.
On the other hand, if you're up against a superbug, hitting those high peak concentrations with intermittent infusion might be the way to go.
Exactly. It's about picking the right weapon for the battle at hand.
Not EI versus 2, but the best choice for that specific patient.
Precisely. And I think the study also emphasizes the need for more research, especially in certain patient groups. The authors themselves suggest focusing on folks with sepsis or septic shock, where even small differences in antibiotic delivery could make a huge impact.
That's a great point. Those are the high-stakes scenarios where we really need to fine-tune our antibiotic strategies.
Absolutely. Every decision counts.
So until then, we need to be thoughtful about our use of EI, remembering that it's not a guaranteed slam dunk.
Well said.
This BEATLE study has given us plenty to chew on, both for our day-to-day practice and the future direction of research.
Agreed. A valuable contribution to this ongoing debate about managing febrile neutropenia.
And a good reminder that we should always be questioning our assumptions, challenging the status quo.
Never stop learning.
Well said. Thanks for joining me on this deep dive. It's been enlightening.
Always a pleasure.
And to all our listeners out there, a huge thank you for tuning in. We'd love to hear your thoughts on this study. How does it impact your approach to febrile neutropenia? What questions has it sparked for you? Keep those brains buzzing, and we'll catch you in the next deep dive.